Blood transfusion in obstetrics. Green Tab Guideline number 47, May 2015. How can the risk of transfusion be reduced? Optimization of hemoglobin in the antenatal period. Diagnosis. Anemia in pregnancy is defined as first trimester hemoglobin of less than 110 grams per liter, second or third trimester hemoglobin of less than 105 grams per liter, and postpartum hemoglobin of less than 100 grams per liter, in line with the British Committee for Standards in Hematology guidance. For normocytic or microcytic anemia, a trial of oral iron should be considered as the first step, and further tests should be undertaken if there is no demonstrable rise in hemoglobin at 2 weeks and compliance has been checked. Pregnant women should be offered screening for anemia at booking and at 28 weeks. Women with multiple pregnancies should have an additional full blood count done at 20 to 24 weeks. If the hemoglobin is less than 110 grams per liter in the first trimester or less than 105 grams per liter in the second or third trimester, consider hematinic deficiency once hemoglobinopathies have been excluded. Serum ferritin is the most useful test for diagnosing iron deficiency, but it is an acute phase reactant. Anemia not due to hematinic deficiency, for example, hemoglobinopathies and bone marrow failure syndromes, should be managed by blood transfusion where appropriate in close conjunction with a hematologist. Treatment and management. Oral iron should be the preferred first-line treatment for iron deficiency. Parenteral iron is indicated when oral iron is not tolerated or absorbed, or patient compliance is in doubt, or if the woman is approaching term and there is insufficient time for oral supplementation to be effective. Intravenous iron products should only be administered when staff trained to evaluate and manage anaphylactic or anaphylactoid reactions, as well as resuscitation facilities, are immediately available. Women should receive information on improvement of dietary iron intake and factors affecting absorption of dietary iron. Antenatal use of iron, with or without folic acid, showed a 50% reduction in the risk of anemia in the third trimester or at delivery. A Cochrane review of studies comparing iron supplementation with no iron or placebo found that iron supplementation decreased the incidence of low birth weight babies and prevented maternal anemia and iron deficiency anemia. A second Cochrane review comparing intermittent versus daily iron supplementation showed that intermittent supplementation produced a similar risk of anemia at term, prematurity, and low birth weight babies, but was associated with fewer side effects. Parenteral therapy offers a shorter duration of treatment and a quicker response than oral therapy. It is, however, more invasive and expensive to administer. Severe allergic reactions are possible with all iron preparations. Intravenous iron products should only be administered when staff trained to evaluate and manage anaphylactic or anaphylactoid reactions, as well as resuscitation facilities, are immediately available. Rich sources of dietary iron are red meat, fish, and poultry. These provide heme iron that is more easily absorbed than non-heme iron, but the latter forms the vast majority of iron taken through the diet. Vitamin C enhances the absorption of non-heme iron, whereas tea and coffee inhibit iron absorption from food. The role of recombinant human erythropoietin for non-end stage renal anemia is still to be established, and it should only be used in the context of a controlled clinical trial or on the expert advice of the hematologist. Active management of the third stage of labor is recommended to minimize blood loss. Women at high risk of hemorrhage should be advised to deliver in hospital. General principles of blood transfusion. Consent for blood transfusion. Valid consent should be obtained where possible prior to administering a blood transfusion. In an emergency where it is not feasible to get consent, information on blood transfusion should be provided retrospectively. The reason for transfusion and a note of the consent discussion should be documented in a patient's case notes. Requirements for group and screen samples and cross-matching. All women should have their blood group and antibody status checked at booking and at 28 weeks of gestation. Group and screen samples used for provision of blood in pregnancy should be less than 3 days old. In a woman at high risk of emergency transfusion, for example, placenta previa, and with no clinically significant alloantibodies, group and screen samples should be sent once a week to exclude or identify any new antibody formation and to keep blood available if necessary. Close liaison with the hospital transfusion laboratory is essential. Women should have a group and screen sample taken in line with clear locally agreed protocols for provision of blood. Maternal red cell antibodies are relatively common. These can cause hemolytic disease of the fetus and newborn, or HDFN, and will also have implications for the selection of blood for transfusion in the mother to avoid the risk of hemolytic transfusion reactions. Accordingly, the blood group and antibody status of the mother should be tested at booking and at 28 weeks of gestation. When red cell antibodies are detected in the booking sample, further testing of maternal blood should be undertaken to determine the specificity and the level of antibody or antibodies and to assess the likelihood of hemolytic disease of the fetus and newborn with early referral to a specialist fetal medicine unit depending on the nature of the antibody, level, and previous history. Transfusion or pregnancy may stimulate the production of unexpected antibodies against red cell antigens through either a primary or secondary immune response. To ensure that the specimen used for compatibility testing is representative of a patient's current immune status, serological studies should be performed using blood collected no more than 3 days in advance of the actual transfusion when the patient has been transfused or pregnant within the preceding 3 months. A formal deviation to the 3-day rule may be used in pregnant women with no clinically significant alloantibodies who require blood standing by for potential obstetric emergencies, for example, placenta previa, with samples sent once a week to the transfusion laboratory for testing. Fetal-maternal hemorrhage constitute a smaller stimulus than transfusion because the number of foreign antigens is limited, and in many pregnancies, the volume of red cells transferred from fetus to mother is too small to stimulate a primary response. Blood product specification in pregnancy and the puerperium. ABO, RHD, and K for Cal compatible red cell units should be transfused. If clinically significant red cell antibodies are present, then blood negative for the relevant antigen should be cross-matched before transfusion. Close liaison with the transfusion laboratory is essential to avoid delay in transfusion in life-threatening hemorrhage. Cytomegalovirus or CMV seronegative red cell and platelet components should be provided for elective transfusions during pregnancy. Previous blood transfusion is an important cause for alloimmunization with antibodies other than anti-D, in particular anti-K, which can cause severe hemolytic disease of the fetus and newborn. Accordingly, unless a woman is known to be K positive, only K negative blood should be used for transfusion in women of childbearing age. Major obstetric hemorrhage protocols must include the provision of emergency blood with immediate issue of Group O, RHD negative, and K negative units, with a switch to group specific blood as soon as feasible. In an emergency such as major hemorrhage, standard leukocyte depleted components should be given to avoid delay, and cytomegalovirus negative blood or platelets are not needed for transfusion during delivery or in the postpartum period. What are the strategies to minimize the use of bank blood? Is there a role for preoperative, pre-delivery autologous blood deposit? Pre-delivery autologous blood deposit is not recommended. Is there a role for intraoperative cell salvage or IOCS? Cell salvage is recommended for patients where the anticipated blood loss is great enough to induce anemia or expected to exceed 20% of estimated blood volume. Consent should be obtained for intraoperative cell salvage where possible, and its use in obstetric patients should be subject to audit and monitoring. Cell salvage should only be performed by multidisciplinary teams who develop regular experience of intraoperative cell salvage. Where intraoperative cell salvage is used during cesarean section in RHD negative, previously non-sensitized women, and where cord blood group is confirmed as RHD positive or unknown, a minimum dose of 1,500 international units of anti-D immunoglobulin should be administered following the reinfusion of salvaged red cells. A maternal blood sample should be taken for estimation of fetal-maternal hemorrhage 30 to 40 minutes after reinfusion in case more anti-D is indicated. Management of obstetric hemorrhage with blood components. There should be a clear local protocol on how to manage major obstetric hemorrhage. The protocol should be updated annually and practiced in skills drills to inform and train relevant personnel. Are there mechanical strategies that can be employed? Clinicians should familiarize themselves with mechanical strategies that can be employed to reduce postpartum blood loss. What blood components can be used for obstetric hemorrhage? When should red cells be used? There are no firm criteria for initiating a red cell transfusion. The decision to provide blood transfusion should be made on clinical and hematological grounds. In an extreme situation and when the blood group is unknown, Group O RHD negative red cells should be given, although they may be incompatible for patients with irregular antibodies. Staff working in obstetric units should be aware of the location of the satellite blood fridge where available and should ensure that access is possible for blood collection. The decision to perform blood transfusion should be made on both clinical and hematological grounds. Blood transfusion is almost always required when the hemoglobin is less than 60 grams per liter, and it is rarely required when the hemoglobin is greater than 100 grams per liter. It should also be remembered that patients with acute hemorrhage can have normal hemoglobin. Hence, the clinical evaluation of the patient in this situation is extremely important. One of the reasons for the delay in blood transfusion during life-threatening bleeding episodes was a lack of understanding concerning the term cross-match, whereby clinicians frequently request cross-match blood without realizing that this could take some time, which is not optimal in an emergency. Thus, in the event of life-threatening hemorrhage, even if a woman has RBC alloantibodies, the transfusion of Group O RHD negative red cells or group-specific red cells must not be delayed. In what circumstances should fresh frozen plasma, or FFP, and cryoprecipitate be used? Fresh frozen plasma at a dose of 12 to 15 milliliters per kilogram should be administered for every 6 units of red cells during major obstetric hemorrhage. Subsequent fresh frozen plasma transfusion should be guided by the results of clotting tests if they are available in a timely manner, aiming to maintain prothrombin time or PT and activated partial thromboplastin time or APTT ratios at less than 1.5 multiply normal. It is essential that regular full blood counts and coagulation screens, PT, APTT, and fibrinogen are performed during the bleeding episode. Cryoprecipitate at a standard dose of 2 5-unit pools should be administered early in major obstetric hemorrhage. Subsequent cryoprecipitate transfusion should be guided by fibrinogen results, aiming to keep levels above 1.5 grams per liter. The fresh frozen plasma and cryoprecipitate should ideally be of the same group as the recipient. If unavailable, fresh frozen plasma of a different ABO group is acceptable, providing that it does not have a high titer of anti-A or anti-B activity. No anti-D prophylaxis is required if a RHD negative woman receives RHD positive fresh frozen plasma or cryoprecipitate. Once the fresh frozen plasma has been ordered, it takes at least 30 minutes to thaw and issue. During this time, resuscitation should be continued with volume expanding fluids or red cells as appropriate. Most units of fresh frozen plasma, as is the case with red cells, platelets, and cryoprecipitate, are not virally inactivated, and that transfusion with these products offers a small risk of transfusion-transmitted infection. Full blood counts play an important role in guiding red cell and platelet transfusion during major hemorrhage, while PT, APTT, and fibrinogen results should be used to guide fresh frozen plasma and cryoprecipitate transfusion respectively. When should platelets be used? Aim to maintain the platelet count above 50, multiply by 10 to the 9th power per liter in the acutely bleeding patient. A platelet transfusion trigger of 75 multiplied by 10 to the 9th power per liter is recommended to provide a margin of safety. The platelets should ideally be group compatible. RHD negative women should also receive RHD negative platelets. Platelet concentrates should ideally be of the same ABO group as the recipient. ABO non-identical platelet transfusions have been associated with poorer platelet count increments. Administration of ABO non-identical platelets is unacceptable transfusion practice, in particular when platelet concentrates are in short supply. If RHD positive platelets are transfused to a RHD negative woman of childbearing potential, anti-D immunoglobulin should be administered. A dose of 250 international units of anti-D immunoglobulin is sufficient to cover 5 adult therapeutic doses of platelets given within a 6-week period. These may be given subcutaneously to minimize bruising and hematomas in thrombocytopenic women. Platelets may be given via an unused blood-giving set, although a platelet-giving set reduces wastage because it has less dead space. Transfusion of platelets through a giving set previously used for red cells is not recommended. Is there a role for near-patient testing of coagulation? Centers that are using thromboelastography or rotation thromboelastometry for guiding blood transfusion during major obstetric hemorrhage must ensure that their transfusion algorithm protocol has been validated and that quality assurance measures are followed. Pharmacological strategies for management of major obstetric hemorrhage. Is there a role for recombinant factor 7A or RF7A therapy? The use of RF7A may be considered as a treatment for life-threatening postpartum hemorrhage, but should not delay or be considered a substitute for a life-saving procedure such as embolization or surgery or transfer to a referral center. In order to ensure the maximum effect of recombinant factor 7A on clot formation, attempts should be made to correct thrombocytopenia, acidosis, and hypofibrinogenemia. Is there a role for fibrinogen concentrate therapy? Fibrinogen concentrate is not licensed in the UK for the management of acquired bleeding disorders. Thus, its use in postpartum hemorrhage should be considered only in the context of clinical trials. Is there a role for antifibrinolytics? For those centers not participating in clinical trials, consideration should be given to using tranexamic acid during major obstetric hemorrhage. Tranexamic acid is a synthetic derivative of the amino acid lysine that reversibly binds to the lysine binding sites of the plasminogen molecule. It prevents activation of plasminogen to plasmine, leading to inhibition of fibrinolysis. How should intrapartum anemia be managed? In addition to major hemorrhage guidelines, obstetric units should have guidelines on criteria for red cell transfusion in anemic women who are not actively bleeding. If the hemoglobin is less than 70 grams per liter in labor or in the immediate postpartum period, the decision to transfuse should be made according to the individual's medical history and symptoms. How should women with postpartum anemia be managed in the postnatal period? If the hemoglobin is less than 70 grams per liter in the postnatal period, where there is no ongoing or threat of bleeding, the decision to transfuse should be made on an informed individual basis. How should women who decline blood products be managed? Hemoglobin should be optimized prior to delivery to prevent avoidable anemia. All women declining blood transfusion require careful multidisciplinary planning with senior clinician input during pregnancy to minimize anemia and to manage blood loss. Early use of iron replacement is indicated with, if needed, use of intravenous iron. Antenatal planning is essential, and hematinic deficiencies should be corrected if the hemoglobin is less than 105 grams per liter for all women before delivery. The treating clinician will need to establish which blood components or blood sparing techniques, for example, clotting factor products, are acceptable. Consent or refusal of blood and components or other transfusion sparing techniques should be discussed and documented during the antenatal period. The women should have an opportunity to discuss consent alone, witness with an experienced clinician. Treating clinicians should ensure that the woman is fully informed of the risk of refusing transfusion and of maternal mortality data for Jehovah Witness compared with non-Jehovah Witness women. This needs to be handled sensitively to avoid any possibility of coercion. Use of pharmacological, mechanical, and surgical procedures to avert the use of bank blood and blood components should be considered early. Intraoperative cell salvage has a role in the management of patients who refuse allogenic blood transfusion.